Morning. Sorry for the late start. We had a little technical difficulties this morning. A quorum being president of the Human Services and Veterans Committee being present, we're going to call this meeting to order. I just wanted to say first that this meeting is being televised and audio taped, and I just want to read the call of the meeting. The Human Services and Veterans Committee will conduct a public hearing to discuss the lessons learned from the death of Laura Levis and to discuss what measures are being enacted to instill a greater level of confidence in the local Cambridge Health Alliance centers to prevent another occurrence of this nature. There's a sign-in sheet for members of the public who would like to sign in, and if you wish to speak, please just indicate on the sign-in sheet. I'd like to start with some introductions, if we can go around and just introduce ourselves. My name is Alana Mallon, I'm the Cambridge City Council.
Hi everyone, Sambal Siddiqui, Cambridge City Council.
Will Durbin, Mayor's Chief of Staff, just filling in, he's on his way.
Lynette Alberti, Chief Nursing Officer for Cambridge Health Alliance.
Patrick Wardell, Chief Executive Officer, CHA.
Josh Posner, President of the Board of Trustees at CHA.
Asad Sayed, Chief Medical Officer, Cambridge Health Alliance.
I'm Peter DeMarco. I'm Laura's husband and a Boston Globe writer.
Quentin Zondervan, Cambridge City Council.
Jan Devereaux, Vice Mayor.
Paula Crane, Deputy City Clerk.
Denise Simmons, Cambridge City Council.
Liana Ascalise, aide to Councillor Mallon.
I want to start by welcoming everybody and thanking everyone for being here this morning. I'm especially grateful to Peter DeMarco, Laura Levis's husband, for being here and sharing his time and thoughts with us this morning. We all know the facts in this terrible tragedy. Early in the morning of September 16, 2016, Laura Levis went to the Somerville Hospital seeking emergency care for an asthma attack. What happened then was a series of missed critical opportunities to save her life. From the inadequate lighting and signage, a locked emergency room door, a 911 call that was placed to a regional call center, to critical details from 911 staff not being relayed to emergency responders. A nurse that didn't leave the hospital door far enough to see Laura on a bench yards away, and many others. Every minute that she wasn't found outside the ER was critical, and all of the emergency systems that Laura placed herself into emergency care failed her. I spent some time listening to the 911 calls, the dispatch between police and fire post the event, and reading every word of this story, and I'm still struck by the tragedy of this preventable death of a 34-year-old woman who had her life in front of her, and by the grief of the loving husband she left behind. This hearing today is not to relitigate those feelings, as there have been very productive and honest conversations between Mr. DeMarco and CHA officials and staff. And I was pleased to see that we're honest and open conversations. But this hearing is an opportunity for the City Council to hear what steps the Cambridge Health Alliance is putting into place in the wake of this tragedy to ensure that Laura's life wasn't in vain, and how the CHA is working to make sure that no one ever loses their life outside the ER doors waiting desperately for help to come. I look forward to hearing an update from the CHA on where things stand to date and when we expect this work to wrap up. But first, I'd really like to invite Laura's husband, Peter, to speak. He has a few things he'd like to say. So go ahead. You have to make sure that the green light is on.
Thank you, Councillor. Excuse me. Thank you, City Council members. I very much want to thank you for pursuing more answers today, more solutions today regarding, of course, Laura's death and Cambridge Health Alliance's actions and response. Before I do that, though, I would just like to tell you a little more about a side of Laura that you may not know too much about, and that was her Cantabrigian side. Laura never resided in Cambridge, but she worked here the last 10 years of her life, first at Buckingham Brown and Nichols, then at Harvard University. As work is for many, Cambridge was her second home. It's where she made many relationships. It's where she got her coffee. It's where she got her manicures. It's where she took her lunch hour to lift weights or stroll the Charles River. It's where we rooted for the Harvard hoops team together. Going back to her college days, her favorite bar was right down the street here, was People's Republic on Mass Ave. And the last summer of her life, Laura began volunteering at the Cambridge Women's Center, giving a seminar on resume writing and answering their hotline on Saturday mornings. Cambridge was a very special place to Laura. So it is very special indeed today that you are holding this hearing in this building to acknowledge that Laura's life should not have ended the way it did, and to acknowledge that changes must be made so that no one else's life ends as hers did. If you read Losing Laura in the Boston Globe last fall, the story that I wrote about her death, you will know that the Cambridge Health Alliance did not withheld the truth from our families for more than 2 years. But if you've continued to read the Globe since then, you also know that they, the people in this room sitting next to me on my right, have tried, I believe in my heart, to do a 180-degree turn. They have tried to be open and honest and work towards solutions. So that is very, so important. I thank them for their effort, and I thank them for being here today. In addition to today's actions, I do hope the Council would also consider honoring Laura's memory by expressing support for 2 bills that we have filed at the State House related to her death. One bill would be called Laura's Law, and that would allow the Department of Public Health to set standards for safe patient access to emergency rooms, as such standards really don't exist right now. The other bill would allow victims of the worst kinds of medical errors a viable way to seek justice through our court system by setting aside state caps on damages in favor of a jury verdict. This avenue was not available to our families, nor is it available to any other patient of Cambridge Health Alliance. I may have a few questions for CHA officials today. If you'd allow me to ask them at an appropriate time, I'd be grateful. But just in closing, thank you for inviting me here today. And most of all, thank you for remembering Laura. It means so much to me.
Thank you, Mr. DeMarco. I do want to call your attention, everyone. I did print out the Laura's Law bill. It is in front of you. If anyone has questions. I do not have the second bill that you mentioned, but I will definitely look that up, and thank you for mentioning it. I would like to now actually ask the CHA to do their presentation, and hopefully some of your questions and some of our questions will be answered, but there will be a time for question and answer after. I do want to recognize that the city manager just joined us, Louis DePasquale. Thank you for being here. So, Mr. Wardell, Mr. Posner, go ahead.
Thank you. I'd like to thank the committee for the opportunity. To be here this morning. Back in November, Mr. DeMarco had afforded us the opportunity to meet with him and to extend in a private setting, our deep remorse for what happened and our deep sympathies for him. And the fact that CHA, a safety net organization that cares so much about access, so profoundly failed Peter and his family. This is an opportunity for us to talk about it in a public setting because the issues that you've raised in your introductory remarks, are ones that are of tremendous importance to us, where we do have knowledge and can be helpful, but at the same time, we also have access to the thoughts and minds of others in healthcare for us to really provide assist in the improvements that are really needed throughout the state of Massachusetts. So we really do appreciate that we're here with you this morning. Equally important, we understand the transparency and accountability to patients and their family is an essential aspect of healthcare delivery. We're also examining what led to the communication breakdown. You invited us here today to discuss the lessons learned from the tragedies and what we are taking, what we're doing to improve safety at CHA, and share our learning across the industry. This morning you'll be hearing from Dr. Asad Sayah, who will talk about the clinical care, key aspects of how an emergency department operates, and process for apology and disclosure around unanticipated outcomes. Lynette Alberti, our Chief Nursing Officer, is leading our emergency access improvement efforts and partners with others across the organization to improve safety and quality. Before turning it over to them, the chair of our board, Mr. Josh Posner, would like to address the committee.
Thank you. First, let me just acknowledge that there are a few other members of our board in the room today. We have Jerry McHugh, who's the vice chair, as well as the two city appointees to the board of CHA, which are city manager Lou DePasquale and Ellen Seminoff. We're here today to discuss our learning and actions surrounding this tragedy. On behalf of the board, I have conveyed and continue to convey our apologies to Peter and Laura's family and our commitment to understanding what happened and what we can do to improve safety, communications, and become a better organization. Our board believes in the mission of CHA as an essential safety health system, safety net health system, and has confidence in the dedicated staff who deliver on that mission every day. We also share, as a board, in the grief expressed by Pat and hope our actions effectively reflect our commitment to addressing this very seriously and systematically. First, within days of Peter's November article in the Globe, we formed a special committee of the Board of Trustees to understand the events related to CHA's internal and external response to Laura's death. We are considering the systemic issues that may have led to the delay in accessing care, as well as communications failures with the family and inside CHA. Second, the board decided to commission a complete review by a respected, independent, outside party. We selected Foley Hoag LLP, a well-respected law firm, to conduct this review. Partners Martha Coakley and Dean Richland are leading the effort, which began in January. We expect the review to be complete in late March and plan to share the results publicly this spring. Third, we are committed to learning and helping others to learn from this sad event and to implementing specific action steps in addition to those that we have already undertaken to ensure that CHA is safer and a stronger organization. As I said to Peter when he came and spoke at our board meeting in November, as tragic as this situation is, it would be even worse if we did not use it to make something good happen. We are committed to doing just that. So now let me turn it over to Asad and Lynette.
Good morning. Let me start by, again, apologizing to Peter and Laura's family for our shortcomings. And thank you for your time. I'm an emergency physician by training with over 30 years of experience in emergency medicine. I'm also past president of the Mass College of Emergency Physicians. Prior to being a chief medical officer, I held the position of chief of emergency medicine for 14 years, 8 of which were at the Cambridge Health Alliance. Let me start by saying I assure everybody that the care provided at the Cambridge Health Alliance Emergency Departments is excellent. The clinical care is absolutely superb. And the clinical care provided to Laura on that tragic morning was absolutely excellent in the emergency department. It's subsequently at the intensive care unit. But as an organization, we definitely failed Laura that morning. Our exterior physical plan, our lighting, our signage, our wayfinding were really not where they need to be. They did not help Laura find her way to the unlocked main entrance of the emergency department at Somerville. Instead, she ended up at the ambulance entrance, and probably many of us would have if we did not know the physical plan and were not familiar with it. The ambulance entrance is locked, as it is in hospitals across the country. To provide access to our EMTs transporting patients that are sick and critical, access that's unblocked, access that's direct, access that's private to those patients. Still, we failed Laura that morning. And there are a lot of lessons that we learned from reviewing how can we do things better? How did this happen? How did this tragedy happen? Since that tragedy, we really assessed what can we do better? How can we improve access and safety to our patients? We reorganized the entrances at the emergency department and added a second entrance that's open 24/7 by the ambulance bay for walk-in patients. An ambulance that's lit, an entrance that's lit with appropriate signage that says emergency right by that spot. We modified the exterior lighting, and we made the lighting brighter at the main entrance and dimmer at the ambulance entrance. And it was actually the reverse at the time. We actually activated sensors at all entrances to our waiting area, to our reception area in the emergency department, that would alert our staff inside the emergency department with a ringing bell as soon as somebody enters our reception area. We also have hired an external consultant to review our wayfinding and access to all three emergency departments and give us best practices on how can we do things better. We are learning, we have done improvements, but there's still opportunities to improve once we get the outcome of the study and the review from our experts. Also, as Mr. Bosner said, we are awaiting the outcome of the special review from Foley-Hoag, and probably there will be more learning there. And as an organization, we are an organization of learning. We will continue to learn and find ways to improve the care of our patients. And how can our patients access our facilities? Because we are responsible for our patients, not only within the walls of the facilities, but when they have intentions to come in and get care. Lynette?
Good morning. I join my colleagues and the staff at CHA in expressing our apologies to Peter and Laura's family. As the Chief Nursing Officer, Senior Vice President for Patient Care Services at CHA, I've been deeply involved in the review and the response to Laura's case, which happened just about a year before I joined the system. In reviewing the events leading up to Laura's admission, we identified a number of issues we needed to address, including communication with 911 and local police, and staff roles, policies, and processes for search of patients on hospital grounds. We now know that Laura's 911 call and the vital information she provided was never shared with the Somerville Hospital ED. The urgency of the situation was not communicated during the first call from the Somerville Police Department, nor when we called the police department back to get Laura's phone number so we could call her and help her find her way. We were told that a police officer had been sent to check the area, and our staff was still trying to identify the address on Tower Street where Laura's phone pinged when the Somerville Fire Department found Laura. Regardless of the specifics, our expectation would be that a public safety officer would go outside to assist the patient in finding their way. This did not happen that night, and the responsibility lies with us as leaders for not assuring that roles and responsibilities were clear to all, not with the individual staff members. Today, we have new systems in place to ensure that our staff have the training, tools, and processes to respond going forward. Nursing staff are responsible first for the patients currently under their care. Safe protocols and systems need to be in place to help when unusual situations arise or for surge situations when the number or complexity of patients can strain our capacity. Public safety officers are now clearly responsible for searches on our property. There is a more formal backup system in place for times when the public safety officers at Somerville Hospital are already occupied and need assistance. We have retrained our staff on emergency access guidelines and reinforced to our staff that they can and should exercise discretion and flexibility to ensure that our obligations are met. We are planning drills to reinforce training and assess performance with expectations. We have also opened a brand new system-wide security hub that is actually based at Somerville Hospital. It is staffed 24/7 and is equipped with a state-of-the-art surveillance system that can surveil all of our campuses across CHA. We have reached out to the local police departments to establish direct communications to the EDs and trained staff on how to gather additional information when a call has confusing or limited information being shared with them. In addition, we have obtained a new address for the Somerville Hospital main entrance and emergency department. It is 33 Tower Street, and that is to eliminate confusion with other entrances. We've updated the GPS markers to provide more accurate directions to those using cell phones and apps to locate the entrance. And as Assad mentioned, we are working together when chairing a group and have consulted with an external expert to reassess our wayfinding across our 3 emergency campuses so that we can continue to learn and improve. Thank you.
So it was a tragic morning. And again, we did fail in multiple ways in providing the appropriate guides and accesses for Laura that morning. But once Laura was brought into the emergency department, our clinical team responded appropriately and the care provided was excellent, and we did review that. She was cared for, she was stabilized, and she was transferred to our ICU at Cambridge. We have conducted a clinical review, and that care was of high quality. And that review, the clinical review, was done not only internally, but also by the Department of Public Health. The transfer happened shortly after 7 o'clock in the morning. And at 7 o'clock, the night team changed its shift. Mr. DeMarco was contacted. He was given the difficult news. He came to the emergency department. And the team that was caring for Laura gave him all the information they knew. There was a lot of information that were necessary for him to know, but they did not know that information to give to him. What they knew is that this was an unusual occurrence. And they communicated that to the emergency department leadership and to our quality and safety department. The quality and safety department did a thorough review and a root cause analysis. And there were findings from the review and the root cause analysis that we're sharing with you this morning. Where we failed is that those findings were not communicated with the clinical team caring for Laura, and more importantly, they were not communicated with Mr. DeMarco and Laura's family. So Mr. DeMarco's contact with the organization was through the clinical team, and the clinical team was giving them all the information they knew. But we as an organization had more information, and we did not share that with him. This was a huge gap. There's a lot of learning, a lot of opportunities for improvement in there. And as an organization, we are very self-critical, and we have added a lot of changes to our processes and policies to make sure that when we get that information is communicated to the clinical team and to the patient's family as we know it. Many of the steps that we have introduced include defining who's the person responsible for that communication. When you don't define that, everybody thinks it's the other person's job. Now there is a definition of one person who would be responsible in that communication. With the review processes, we added steps to remind people doing the review, is communication needed with the clinical team and with the family? Is there a need for disclosure and apology? Who's responsible for that? And did the clinical team or the family understand what we're trying to communicate, which is just as important? We're still trying to identify ways to improve this and gaps to say whether this issue is a clinical or non-clinical. We're very good about communicating issues that are clinical. But when informations are discovered that are non-clinical, particularly outside the hospital, now it is emphasized that that information is also essential to communicate. And we're hoping to share a lot of that learning inside and outside the organization and the industry at large eventually, because there is a need for that learning to happen at the industry level. Josh? Or Pat?
One of the things when we first had the opportunity to meet with Peter, what was clear to us is that there may be a role for a CHA in the creation of a legacy for Laura. We stand committed to working with Senator Jalen and Rep. Barber in support of the bill that was referenced earlier. And very importantly, we stand ready when the time is right to speak with Mr. DeMarco and perhaps others in Laura's family.
Mr. Wardell, do you mind just pulling the microphone a little bit closer? I don't think people can hear you.
Sorry about that. We would like to think that we have something to offer to Peter and his family in terms of assisting them in a proper legacy for the untimely death of his wife.
That's the end of our presentation.
Thank you all very much for that presentation. I know I have a lot of questions, but I'm going to turn it over to my colleagues to see if anyone has any questions at this point for CHA or for Mr. DeMarco.
I want to first Amir to your co-chair if she wants to say something. Okay, thank you.
Councilor Simmons.
Thank you, Madam Chair. First, to Mr. DeMarco, I personally want to extend my sincerest condolences to you and your family. I remember I did reach out to you a little while ago. I think it was around January 7th, and I'm sorry we haven't met face to face before now, but again, I wanted to extend my sincerest condolences.
And thank you, Councilor, for co-chairing this hearing. Thank you for taking an interest. Thank you for reaching out to me.
Absolutely. You know, it takes a great deal of strength and perseverance to do the kind of advocacy that you're doing, and I want to thank you for that. We did not know Laura before and now, and now that we know who she is, because I'm never going to talk to her in the past tense. Now that we know who she is, as she counsels us in her way, what can we do to make it better going forward? I know you said that she didn't live in, you guys did not live in Cambridge, but she was clearly a part of the fabric of our city. And in that context, I hope that as she gave to us in her way, in her many iterations, we will give to you and your family as much and then more. As many have said and will say over and over, is what can we do to be better so there's no other tragedies like the one that happened to Laura. So please, I think I can say without reservation that you certainly have us under your wings.
Well, thank you for saying that. That means a lot.
I yield the floor, Madam Chair.
Through you, Councillor Mallon, to Mr. DeMarco, to CHA, these, I heard the word shortcomings, and, these weren't shortcomings, they were complete failures. And I think when we think about transparency and accountability, which this council stands for and promotes, I think we have to think about that standard and what that means. And I feel conflicted because the transparency piece, it feels so delayed, and it doesn't feel enough. And even the accountability piece, I think I want to, hopefully the report from Foley Hoag will show us a little bit more, but I think the accountability piece is something that we have to keep thinking about. And how is CHA going to be held accountable? And I think protecting and sharing Laura's legacy is very important in doing that. I think thinking about ways the council can support this legislation. I think I speak for many of us that would, we're happy to write a resolution. We're happy to advocate with you, not only on this bill, but the other important bill that I personally think is critical, and about removing the cap. So I thank you for coming and sharing. I think we all have a responsibility to think about how we can be held accountable here. And I'm just so very sorry for your loss.
Thank you so much, Councillor. Thank you for your support now and hopefully going forward as well.
Councillor Zondervan.
Thank you, Madam Chair, and through you, my condolences as well, Peter. I'm really heartbroken by this tragedy, and I'm glad that we are having the right and necessary conversations about what we can do better. But I also recognize that nothing we do or say can make up for your loss. So I'm sorry for that as well.
Thank you again as well. Thank you for caring. Thank you.
Vice Mayor.
Thank you. Well, I will echo all of what my colleagues have said. This is very difficult to hear, and I'm sure to relive, and I'm sure also to admit. So I appreciate everyone's candor and honesty today. I would ask, you've talked about new systems and practices and a new surveillance center. Have there been occasions where these new practices have come into play already? I mean, are you seeing an impact? I know you can't talk about specific individuals, but have there been other times when you've seen that this is already having an impact? or is it too soon?
Well, I don't have data, but there's been at least 2 situations that come to mind. Interesting, the 2 situations, neither one was at Somerville. One was at Everett and one was at Cambridge, where our interventions and our education came into play and led to timely support of patients. One was not even in the emergency department, and one was brought into the emergency department in a timely way. So anecdotes, yes. Data is too soon to tell.
Thank you.
Councillor Simmons?
Thank you, Madam Chair. Through you to Mr. Waddell and Mr. Posner. Just a few questions. You've talked about what you put in place, and I say this to you, but also is to us as well. The City of Cambridge, the City Council has no real jurisdiction over the CHA. The City Manager appoints members to the board, but we do not write your rules or run the hospital. And so I say that is that we do have, I would say, an extraordinarily good working relationship. And so to that end, my question is this. You've put together rules and practices so that this doesn't happen again. My question to follow up on that is it codified? Are you training? Are you going to test and retest? And what I mean by that is, what happens oftentimes, the appropriate response is the response that you've taken, a little late, but the response that you've taken is appropriate. But what I find is the further we get from the incidents, we begin to forget what we've done. And so what I'm looking from you is something in writing that says, I heard what you said, and I don't know, Madam Chair, you may already have it, but I would love to see in writing what you've done so far, what you plan to do. And I want to see like a plan, like a 5-year plan. And I want to see in that 5-year plan where you're going to go back and make sure that plan is working. Who's getting trained? How often they're trained? Where you saw deficiencies? How you corrected them? Because the only way that we can make sure that 10, 15 years from now this doesn't happen is if we're constantly looking to see if we're doing the job appropriately. So where I can certainly acknowledge what you've said that you've done, for me, I would appreciate seeing it in writing with dates, but I also want to look out forward and say, and this is what we plan to do, this is how we're going to look back and reassess how well we've done it and made appropriate changes. I think that would be most helpful, because that's the way you can assure that when we don't forget the mistakes that we've made and the ways we have fixed them, but that we are constantly making improvements, we're being held accountable, and others can hold us accountable because it's in writing. Thank you, Madam Chair.
Thank you, Councillor, and I would echo those sentiments. I'm wondering if that will be part of the report, or could be part of the report that was made public at the end of March or early this spring.
I think where I'd like to start is that it is particularly important, I think, when we are trying to address what is a very critical part of our response, that we are able to build in up front what means we will have for review, and make certain that as time passes that we don't lose the focus that we need. And it's in that regard that over the last few years at CHA, we have had a very strong emphasis around process improvement techniques. We currently have 33 different project improvement activities going on at the CHA. And it's very important that we provide the tools and the resources for our staff so that they can do a good job. So I couldn't agree with you more that it's critical for us to build in up front that means of review. And that means of review starts with engaging the workforce in coming up with strategies that address critical issues at CHA. CHA, the The care is excellent, but there's no question how fundamentally we failed Mr. DeMarco and his family as part of this. And we will certainly build in to any improvement this revisiting over time so that we can make things better and better.
Thank you. If my colleagues don't have any more questions, I have a few. Councilor Zondervan.
Thank you, Madam Chair. Through you, I do have a question. As a technologist myself, I've long been frustrated by the lag between new innovations that we are able to develop in the software industry and their adoption by the medical profession. And in particular, I think most of us are aware that we can order a ride from Lyft or Uber, and our location is very accurately communicated to the driver. What will it take for that kind of transmission of that same information to happen through the 911 system?
Let me try this on. Well, it's a great question. Let me just revisit one piece about the location of the Cambridge Health Alliance. And through this review, actually, we discovered that if you ask Uber to drive you to the Somerville Hospital, they actually would drive you to the Highland entrance, not to the main entrance. And so we were able to change the address of the hospital, as was mentioned earlier, to be on Tower Street. So when you Google the hospital, you actually come to the main entrance of the hospital versus the clinical outpatient clinic. Regarding 911, my background as an emergency physician is in EMS, Emergency Medical Services and Disaster Preparedness. So this is part of my expertise. And in general, that technology is, as you say, is about 15, 20 years behind. Mm-hmm. Through a lot of work nationally, we're able to enhance, to move from 911 to E911. So when the caller is calling, at least from a land phone, the address would be found. And more recently, through a cell phone. But that's not completely adopted nationwide. Now there is a move to make that national. There's actually a national bill to make that a requirement for all municipalities to adopt locating the caller based from a cell phone, not through a region, but actually through the location of the cell phone, moving from a tower to an actual pinning location. There's a lot of work that needs to happen. As you well know, that most 911 systems are run by municipalities. There's a lot of rules and laws and regulations, and really there's a need for standardization and standards across the country to do that. And we need to move from more local standards to national standards to do this. We are fortunate in Massachusetts that our systems are, although they're still somewhat archaic, way more advanced than a lot of systems around the country. And there's still a lot of opportunities for improvement there.
Councilor Simmons has a follow-up question.
Thank you, Madam Chair, through you too. And I'm sorry, I can't remember your name.
Assad.
Assad?
Mm-hmm.
Thank you. Assad. Mr. or Doctor?
Doctor.
Dr. Assad. You talked about 911, and I know it has been the case, and maybe, I don't know, Mr. DePasquale is here as well. When you call 911 from your cell phone, it typically goes to the state police, does it not? And see, that's a huge problem. I just bring this to the council. How do we influence public policy? Because everyone's first inclination is to dial 911. I've even told my children to put Cambridge Police and put the phone number in, but say 911 Cambridge Police, so that it will dial the police department and not 911, because precious time is lost because it goes to the state police and Lord knows what they do with it. There's critical time that's missed, and I don't know if this is something that we want to take up in public safety with you, Madam Co-Chairs, but it's something that we really need to put some pressure on, because I think, speaking of something archaic, 911 works well with a landline, but who uses them anymore? Everyone uses cell phones. And so if you, as I said, if you dial 911, you're going to, wherever you are, I believe, in the country, you'll end up calling the state police and not the local police. And so that is indeed a problem.
Thank you for that comment. I'm just going to quickly, I did speak with Christina Jacoby yesterday of 911, and Cambridge does have next-gen 911, which will send your local call to the local 911. That's not true in every community, and there's certainly, the technology needs to be a lot better. As you said, Councillor Zondervan, if Uber knows exactly where I am, my 911 call should know exactly where I am as well. Ms. Jacoby could not be here this morning to speak to some of these 911 questions, but we can certainly have a conversation at a different time if we want more information about the next gen and how 911 calls here happen in Cambridge. As I said, Cambridge Health Alliance operates in a number of other communities that may not have that same technology. So, Vice Mayor, did you still want to?
No, that was what I was going to mention, because we did have a discussion about that at the council following a policy order, and we had a memo from our emergency communications department about the various enhanced 911 systems that they're putting in place. So that's on the public record. I think it was maybe in January or late last year. And it was in part prompted exactly by this situation.
Thank you. I was relaying to Mr. DeMarco this morning that I actually called 911 last year and was routed to the state police, and I was surprised how many rings it took to get me back to the local police. And just that critical time, if we're talking about Laura's situation, every single minute counted. And that's true of many, many times where you call 911. Every second, every minute is critical. So any kind of technological advances we can make in this area, I think is important. When I was doing some reading yesterday about 911 calls, I think Mr. DeMarco pointed out in one of his articles that the FCC has estimated that 10,000 deaths could be prevented in the U.S. every year if emergency responders could get there 1 minute earlier. So every second counts. I do have a couple of questions for CHA before we move. I'm going to allow Mr. DeMarco also, I'm sure he has some questions before we move to public comment. I think one of the things that prompted this particular policy order by Councillor Simmons was communication. We all read about this in the Boston Globe, and I know that there have been significant immediate changes that the CHA has put into place around your own communication in your own organization, but public health officials were not notified in this situation, and neither were the City Council here in Cambridge, and I don't know about the other communities. What kind of external communication protocols have you put into place since this incident? If you could speak to that, that would be great.
Thank you for the question. It's a great question. I don't think you can ever communicate enough. I think communication is something we need to do better across the board. And we've been working very closely with our community department to create those policies and procedures. And I know that a lot of work is done on individual basis through many of the folks that work within the organization. There is now a communication tree that was created within the organization to relay information and important critical news or intervention or stories to our stakeholders, whether they are in the public sector or in the community or in government or Department of Public Health. And that is managed through our community department, through Mary's shop, Mary Casesso's shop. Communication, a lot of it is done on multiple levels. Some of it is through a press release, but a lot of it in our organization is done on one-to-one by telephone calls and individual contacts. And there's still opportunities for improvement. One of the things that we are reviewing, still how can we communicate better. We talked about communication within the clinical team and with the families, and there's opportunities to do that better, as well as opportunities to improve on communications externally.
Thank you. I think obviously the communication between your medical staff and the families affected is the most critical piece, but just keeping in mind that there are public safety officers, there's city councilors, there's people who really need to know that this has happened to respond in an adequate fashion. And our city manager would like to speak to that as well.
Through you, Madam Chair, the one thing that we have clearly talked about as a board and in dealing with Mary, and I think you've seen some examples of it, is that now once that chain is sent out, the council gets notified immediately, as well as all the other elected officials. So it is something we should have had in place a lot earlier, but we now have something in place that once anything goes out, the council is notified immediately, and I've been working closely with Mary to make sure that happens, and that will continue to happen.
Okay, thank you very much for that. And I just wanted to recognize that I should have done this earlier, but I'm just noticing Ellen Semenoff, our Assistant City Manager for Human Services, is here, and as well as Claude Alex Jacob, who is our Chief Public Health Officer, is here. Just wanted to recognize that they're both in the audience. In terms of the immediate interventions at the Somerville campus, you mentioned lighting, signage, another door. I was actually speaking with somebody this morning who said that they ran into an elderly woman on Cambridge Street outside the Cambridge Hospital recently, who was trying to go into the ambulance bays right off of Cambridge Street looking for the hospital. I know that there have been some wayfinding put into place immediately at Somerville Hospital. Can you speak a little bit about what's being done at your other facilities, particularly the Cambridge Hospital, to ensure that something like that doesn't happen at the Cambridge Hospital as well?
Thank you. We have a group that has formed well, let me back up. Immediately after this incident occurred, there was a group that formed and did a root cause analysis and put action plans in place that primarily focused around Somerville Hospital. But in light of the fact that this tragic occurrence is come to light again, we've obviously stepped back to say, let's look at the original action plan. What can we do differently? And how can we spread this effort across all three hospitals? As a part of that, the group has consulted with a professional external firm, and they have done an assessment speaking with staff, with patients, and have gone to each of the facilities both at day and at night, and have provided, we received this several weeks ago, a very comprehensive assessment with pictures of before and after and what their recommendations are for signage and wayfinding for all three campuses. So we are in the process of evaluating that recommendation right now. Is that helpful?
Yes, and just quickly, I know that Councillor Simmons mentioned this going forward piece that's going to be critical, right? It's not just this kind of what's happening right now. I'm wondering if there's a way to survey patients going forward who entered the emergency room around wayfinding, just to see if that data would show you whether or not they wandered around looking for the door. Was it clearly marked? Just that going forward piece, I think some kind of survey when people are leaving the emergency room just to find out about their wayfinding experience would probably be helpful. Vice Mayor.
Thank you. Just a follow-up question. I know that you're obviously focused on your own hospitals appropriately. So I've heard that other hospitals, private hospitals in the area, are also reviewing all of their own policies. And I wondered if there is the potential for CHA, once you've sort of finished the process, to hold some sort of educational forum and invite members of the medical community to come and learn from what you're putting into place and talk about their own. I mean, maybe you're already thinking about that, but I know that we had somebody said he had taken his wife to Mount Auburn Hospital and couldn't see the sign clearly, and there was a tree, and I'm sure that other hospitals are thinking about this as well.
That's a great question. And we've been contacted informally through a lot of organizations within the area, and obviously we have a lot of contacts and people are calling us. And we're still in the discovery and the improvement processes. I've been working with the Mass Hospital Association, been in contact with them, and we are planning a forum sometimes between May and June that will be announced to all hospitals and organizations around the state and maybe outside the state. And MHA is planning to produce a white paper related to this work through a lot of our learning and others, a communication that goes out to the organizations within Massachusetts. So, yes.
Thank you for that question, Vice Mayor. I was just remembering that I had to go to the emergency room at Mount Auburn this summer with a family member, and I didn't realize that you had to go inside the garage and to get to the emergency room. So I have another question around notifying a family member protocol, and that seemed to be something that there was a lag time in when Laura was admitted finally and when Mr. DeMarco was actually contacted, which occurred after a shift change, which was part of the communication breakdown. What is the protocol going forward for notifying somebody's immediate emergency contact to ensure that somebody is there with that patient? I'm just wondering what the protocol going forward is going to be.
So the protocol has always been to contact the family. When Laura was brought to the emergency department, she was obviously in critical condition, and the focus of the clinical team was to take care of her clinically and make sure that she's stabilized. That takes time. It is not a 5 minutes or a 30-minute intervention. It takes time to get somebody stabilized in that condition. Once her condition was stabilized and a plan was formulated upon what is the next step, the team looked in the medical staff record and found the next of kin, and that's when Mr. DeMarco was contacted. Could that have happened earlier? Possibly. But again, the focus of the team at the time was to take care of Laura's clinical condition and make sure that she's stabilized and the care was appropriate and the handoff to the next group was done in an appropriate way. So I had the opportunity to speak with both emergency physicians, the emergency physician that took care of Laura, the night shift, and the emergency physician that communicated and was there when Mr. DeMarco came that morning. And both are devastated. Both are clear that the clinical care was absolutely appropriate. They basically stated we did our best and we communicated everything we could with the information we had. So from a clinical point of view, if I'm going to put myself as an emergency physician and a member of the medical staff in the emergency department, maybe things could have been communicated earlier. But again, remember, the focus of the clinical team, we're all clinicians, is to take care of the patient clinically first. And then we can do the communication.
Thank you. I understand that the clinical team, obviously, their first goal is to make sure that a patient is well and healthy. But I'm assuming there's other people working in the emergency room who aren't part of the clinical team that could be making those calls, looking up those medical records. I know that I was in the emergency room once with my daughter, and within minutes of me entering the emergency room, my pediatrician was on the phone with me. She got a ping that I had checked in with my daughter. Yeah. So I know that the processes are in place. I just don't know how going forward there could be a process where a next of kin gets pinged by a non-clinical staff member who isn't currently working on stabilizing a patient. If there isn't currently a thinking around that or trying to figure that piece out, I think that's a critical piece because a shift change happens all the time, and you do miss out on critical communication pieces.
You're absolutely right. We actually, as an organization, pioneered that ping to the primary care physician 10 years ago by automating it. So as soon as you registered, your PCP gets a call and an email. And we actually have done a lot of teaching and learning around the country on how to do this. Totally agree. Again, remember it was a night shift. The clinical staff and the support staff is not the same at night as during the day. People were working on taking care of patients. And I truly agree that there is an opportunity for improvement on communication. And communication should have happened earlier through to the family.
Madam Chair, a follow-up?
Councilor Simmons.
Thank you. I think you make a critical point there. You say it should have been made sooner. Maybe it should have been made different. And what you're saying is, so there's a system from what you say, Dr. Assad, to contact the pediatrician. And I understand what you're saying. We did what we were supposed to do, which was stabilize the young lady. So what I'm thinking, and maybe you're thinking the same way, is so what could be, who wasn't in the room that could have provided the service? So while you're doing what you're supposed to be doing and following the letter and the spirit of the practice, there's someone, it's social worker or I don't know the name of the person that is now running alongside that patient trying to get critical data about next to kin if the person arrives by themselves. So I would say, how do we not look at what we did do, but what was missing in what we did, and how do we fill that gap?
Absolutely, opportunities for improvement. And we are working on improving the processes and making sure that communication with the family, next of kin, and you know, the other people is done in a timely way, as early as possible. Absolutely.
Madam Chair, I apologize. I have to leave. I have
Thank you for being here, Councilor Simmons.
Thank you, Councilor
Zondervan?
Simmons.
And then, no, he goes first. He can go first.
Thank you, Madam Chair. Through you, a follow-up question. Dr. Assad, you mentioned that your team had pioneered automatically contacting the PCP, which is a great innovation. So would it be possible to similarly automate contact of next of kin if that information is available in the file?
That's a great question, and this is something we're looking into to see if this is something that we could automate.
Thank you.
Vice Mayor?
I guess my follow-up question is, if someone comes to the emergency room unaccompanied and is not a regular patient of that hospital, how do you actually find out who the next of kin is?
It's a great question. Obviously, if the patient is capable
Conscious,
of
they can tell you,
communicating,
yeah.
then that's how we go. If the patient is not, then our focus is to take care of the patient.
Well, obviously, yeah.
As clinicians. And then once we take care of that, then we will, obviously, we check the patient's belongings, we call the police department, you know, and many times there are situations where patients are admitted as John Doe or Jane Doe until that's found. It may not happen while the patient in the emergency department, but we do our best to try to find that out.
Is there a best practice for individuals? I mean, most of us have phones that have a lot of personal information, but most of those phones are password protected. We might have a driver's license. Is there something that we should be carrying in our wallets that can help
That's a great
in these
question.
rare, hopefully rare instances?
It's a great question. It's one of the things that I do teach. It's very important to carry a card, and actually those cards, you can find them. We so much technology focused that sometimes paper works best, believe it or not. And the card would have the contact information. If you're taking any medications, any medical history, any allergies are very critical for the emergency department. And if you have a primary care physicians or any place where we can access records, because many times we are taking care of patients completely blind, and we'll do our best based on the information we have in front of us. And the more information we have, the better decisions we can make. So I do that. I do carry a card myself that has my information and my wife's telephone number and cell number, just in case, you know, I'm unconscious. So that's very important. I would recommend that.
I just want to add that in my cell phone, I have an ICE in case of emergency, and that bypasses your password. So if you fill out in your cell phone who you want contacted in an emergency, you press emergency and it comes up, and you can bypass your password protection. I have that filled out in my phone. I recommend people to do that.
Thank you. I also have an ICE, and I've never had to use it, but I think it's a critical piece of information, especially for emergency responders. I did want to give Mr. DeMarco a chance to ask some questions before we go to public comment. Go ahead.
Thank you again, Counselor. Thank you. Thank you for your presentation today as well, officials. I maybe just a few things, just based on what you've spoken about today. I was curious, Dr. Sayo, you said there have been 2 instances now since Laura's death where potentially changes at CHA have assisted in helping someone find their way to the hospital or to the emergency room. And I know we had spoken about one of them before that happened at Everett Hospital. Maybe you could review that one. And what was the second one at Cambridge Hospital now? That's new to me.
Yeah. Obviously, there's the patient confidentiality things. I would stay really at a high level. It was an evening time, and a lab tech was leaving the hospital at the end of a shift, maybe 7, 8 o'clock night, and found a young man by the main entrance who just was semi-conscious. And there was another person standing next to him. She immediately walked in and alerted folks, came outside to start assisting the young man and his friend. And it was found that there were 4 teenagers at the time who had all 4 of them overdosed. And fortunately, without that person acting, who's technically not their responsibility, they were outside the hospital on a sidewalk, we could have had tragic outcomes in there. And a lot of that was related to the education that we've done to all our staff, related to the responsibility, our responsibility of caring for patients, not only within the hospital, but outside the hospital. Now, the lab tech, she's an exceptional person, and would she have done the same thing with or without the education, one would ask. But she did an amazing work, and the staff responded absolutely appropriately with all the equipment and the tools to take care of these 4 teenagers who did very well. The second situation was a middle-aged gentleman coming to the emergency department at Cambridge after hours, and our public safety folks met him right as soon as he walked in, and brought him to the emergency department, and he had some shortness of breath, and he was cared for.
Did he make it inside the building?
He was right coming inside the main entrance.
The main entrance. He did come in the main entrance. Yeah. Okay, sure. Nurse Alberti, you mentioned, of course, the additional review that Cambridge Health Alliance has asked. Has now you have a evaluation from an outside agency about lighting, signage, wayfinding. Could you elaborate more on some of the findings of that evaluation? What else may be needed at the 3 hospitals? Where are you in that review?
I didn't really come prepared to speak to the details of the evaluation. It's about a 75-page document, but we did look through all of it. And some of it has to do with just standardizing, like on each sign we have, it'll say Cambridge Hospital Emergency below it. So they looked at making sure that the order is the same in every hospital and standardizing the signage so that emergency stands out appropriately on those signs. That's one example. There were changing the fonts to make them all similar. There was some lumen recommendations. There were additional signages recommended. You mentioned a tree at Mount Auburn. One of the locations had a tree that potentially could partially obstruct. I believe that was at Everett. I can't recall specifically now. But I will say we were very impressed with the recommendations, and we're going to be looking at them and taking them very seriously as to what we need to implement.
What is the name of the firm that conducted that review?
96 Point.
96 Point. Where are they out of?
somewhere in Massachusetts, Cambridge.
Cambridge, okay. Would you be able to provide me a copy of that report?
Certainly.
Oh, great. Does that report also contain any recommendations regarding monitoring of other prominent hospital doors that may be locked, aside from emergency room doors, specific emergency room doors?
There wasn't recommendations about monitoring, if I recall, but there were recommendations about signage on those doors.
From our previous discussions, have there been any more discussions at CHA about monitoring other prominent hospital doors, installing either panic buttons or doorbells or video intercoms, or could you, Dr. Saya, or please, any?
So one of the things that we're looking at and is, I don't know if you've seen those blue lights with the intercoms in many of the buildings. We're looking at that technology to deploy within the organizations in particular areas, and that will be an intercom with a blue light, so somebody can go there. You can see the light from far away, and there will be a two-way video with intercom with our communication center. So not only that area would be monitored, but also the patient or the visitor would have opportunity to call for help and get two-way communication from there.
Such as a location, such as maybe on Highland Avenue in Somerville?
Yes, that would be one of them.
That would be one of them. Yeah. At Cambridge Hospital, are there any potential locations for that?
I really haven't seen, I mean, public safety knows, and the folks looking at that. I'm sure there could be locations there. I know there's a couple at Somerville, 2 or 3 at Everett, and 2 or 3 at Cambridge.
Okay. Good to hear. As for monitoring, your command center is now up and running, and so this is, could you just explain again what, how many hospitals are monitored, how many hours are they monitored, how many doors are monitored? You explained that January was going to be a transition to going up full time, I believe. So has that been completed? Maybe you could just give me the overview of the eyes and ears now that are in place through your Somerville Hospital Public Safety Hub.
So the Central Monitoring Center is basically a 24/7 manned command center with multiple large screen TVs that are overlooking the over 500 cameras throughout the system, not only in the hospital but also in the clinics. And also the system has, you probably know more than I do about the software, intelligence software that would gravitate to areas with activities, whether it's motions or multiple activities. So because there's so many cameras, it will refocus the person that's monitoring in that direction. The other thing that we're monitoring are all 911 calls in and out of the system. So as they're coming in, the call would go to, if it's coming from the police department, it would go both to where the place is and also go to the center, and it will be recorded. And if there are any 911 calls coming out of our system from any of the clinics, they will also go indirectly to the center, so they will be monitored and recorded. So, there's multiple ways to improve that. Again, I'm not the tech expert in that, but, I would invite anybody any of the counselors or any of the public, if they're interested, to come in and look at this. And it's pretty impressive.
That's good to hear as well. And there are 1-2 people who monitor that in the security staff. How many physical bodies are monitoring at night? I
know it's manned 24/7. I don't know how many people are there at the same time.
Okay. It's one person, but that's that person's sole responsibility. They would not be asked to do a patient watch per se, or they would not be.
They're actually not public safety officers. It's a specific role that they've been hired for. So they're hired for that department, and there's a manager of that department as well.
Okay. For Mr. Wardell, you mentioned earlier in your discussion today that CHA would be in support of the legislation that I have filed with Senator Jalen and Representative Barber and others. Could you clarify how far would you be willing to vocally support both these pieces of legislation in Laura's honor?
Yes, I would. I think that in addition to that, we would like to participate along with yourself and our legislators in any suggestions that we may have that would, in our mind, improve upon the plan as it's currently described. We also would, through the contacts that we have, would be able to partner with you to meet with the MHA or to meet with other organizations so that this can be something that the industry can support while still fully achieving what you're attempting to do in Laura's honor.
I'm glad you've extended that offer, and that sounds like something that we certainly have to look into doing. That's great to hear. As well as Dr. Saya, you mentioned in May or June. This was extremely heartening to hear that you're now actually targeting a date of time to hold a forum to discuss with other hospitals the lessons that are learned. I know you're still waiting for the Foley Hoag review, but that's incredibly heartening to hear. And if you would consider me being a part of that as well.
Absolutely.
I guess I just have one other question, and it's for all of you here sitting here. Mr. Wardell, I know that you've announced your retirement coming, and I guess I would like just to hear from all of you what how will CHA honor your commitment to change and to honoring Laura in the next few months while you're still CEO, Mr. Wardell, and also when you're gone, and how will Laura's story be conveyed to your replacement, I guess?
If I can say, the point of continuity.
Mr. Wardell, do you mind just speaking to the mic?
I'll never learn, sorry. The point of continuity, I think, is our board. They have placed a very clear expectation on leadership, managerial leadership, that we create an atmosphere that is receptive to the ideas that you have put forward, and for us to accomplish the things that we have on the list, and be mindful of what Councilwoman Simmons pointed out, which is good intentions fade. Let's make sure that we build it in. It is true I did tender my retirement recently, but it was also with the understanding that I intend to be here so that we can have those conversations and that we can feel as if what we have accomplished is something that is at least the beginning of the legacy that you'd like to leave to honor your deceased wife.
If I can just add to that, as the board chair, we take this very seriously. We are completely committed to seeing this through, to using this as fuel to improve the organization, to address the weaknesses, failures, not shortcomings. And the board is unified in that feeling. We're a terrific organization. There's wonderful people who work at CHA. Our mission is very important to this city and to all the communities that we serve. But we can and will continue to improve and to do better. As far as a legacy and as far as honoring Laura's death, I know I personally look forward to talking to you about ideas that I have, I'm sure ideas that you have, that can do that. And Some of it will be around improvements within our organization. Some of it, I hope, will be improvements that other healthcare providers will understand and will make themselves, because there, but for the grace of God, go many organizations. I think there's a lot that we can do and that we really have an obligation to do as a result of this tragedy and as a result of the opportunity that the tragedy presents to all of us.
Thank you.
Thank you, and thank you for asking that question. Mr. Posner and I had that exact conversation yesterday about the transition and how the board would be continuing this work on, even in Mr. Wardell's absence and in his replacement. So thank you for asking that question. At this point, we're just going to turn to public comment. It looks like we have one member of the public that would like to speak. Mark Levy, if you'd like to come up.
How's that? My name is Mark Levy. I live on Oxford Street, and I have the privilege of editing Sue Reinert when she writes about CHA for the website Cambridge Day. I was struck by Councillor Siddiqui's comments about transparency and accountability, and I think it shouldn't be lost that while Mr. DeMarco first wrote about this death in November 2018, hopefully helping move CHA toward more transparency and accountability, it was not our first chance to learn about the death. Sue Reinert learned of it in late 2017 and asked CHA about it, but CHA chose at that time not to be transparent about it. While I understand that many people here learned about this incident by reading the Globe in November 2018, it was first reported publicly January 2nd, 2018, in Sue Reinert's reporting in Cambridge Day. So there's something symptomatic here about how institutions try to handle media these days. They put out press releases and, excuse me, and they do social media. They post on Facebook, they tweet, they even make videos for YouTube. But when a member of the media asks questions, those questions are often dismissed. They're sometimes treated with hostility, and the answers are put off and often incomplete. This is the approach taken by the city of Cambridge also, unfortunately. Sue Reinert is an excellent reporter and a very fair one who's written regularly for years now about CHA advances, programs, research, and finances, good news, bad news, everything in between. She's the only person doing regular coverage of CHA for the people of Cambridge. But her relations with CHA can be difficult. From my perspective, it doesn't feel like CHA has been transparent and accountable always. And I can make it feel sometimes like CHA is hiding something, even when it's not. So it's heartening to hear Dr. Saya say that he doesn't think you can ever communicate enough. And I hope that approach is truly embraced. I want to share a brief email exchange I had with the press office at CHA that resulted from Sue's regularly writing about CHA and the subsequent need for images to illustrate them. So I wrote and I asked for an arrange a visit to Cambridge Hospital by a photographer to get images Cambridge Day can use in the months and years to come for general coverage, such as when Sue Reinert writes about finance reports, alliance accomplishments, etc. What can we do to make that happen? And the response that came was, thanks for the note. As we do with other outlets, I'm happy to coordinate photography for each story as needed. Per our protocols, we don't coordinate shoots to generate a photo inventory for an individual media outlet. Should you want to take any exterior shots, I'm happy to accompany a photographer in accordance with privacy regulations. We may also have some updated ones on file. So that is somewhat helpful, but it's not totally practical for the way Cambridge Day operates. And it raises the risk that the coverage is going to be conditional, that when it's good news, we'd be invited in, that when it's bad news, we'd be like, no, not this time. So I asked, what is the reasoning behind those protocols? And the response came back, I've been doing this for more than a decade and have never fielded that type of request. We wouldn't do it if the Boston Globe or New York Times asked. We're certainly open to arranging shoots to support individual stories. I said, I don't think the Times or even the Globe would or has given the CHA such sustained and regular coverage. We take the Alliance very seriously and place an importance on those institutions that those institutions and even the Chronicle do not. So our needs are a little different than those of the Globe and Times, and I was wondering at the reasoning and concerns behind those protocols. There was no reply. That was the end of the communications from CHA. There was a decision on the part of CHA, just like its decision not to answer Sue Reiner's questions about a death outside the Somerville Hospital ER in September 2016. What we know now is that refusing to handle the situation doesn't always make that situation go away, and sometimes it makes the situation worse. Thank you.
Thank you. Are there any other members of the public that would like to speak that have not signed up? Hearing no one, I'm going to close public comment. I do have another question that I'm just going to go ahead and ask. Ambulances are expensive, and a growing number of younger people are using rideshare organizations like Lyft or Uber to get to the hospital. In fact, there's a whole page of the Lyft website instructing people on how to do so. Is there any discussion about partnering with these TNCs or Uber and Lyft to ping the hospital if a patient's on its way, or actually working with Uber and Lyft to talk about ambulance procedures? It seems like, just in this discussion about Somerville Hospital, ambulance procedures are different than a walk-in, right? If somebody's in critical condition, needs to get somewhere quickly, they get to go to a different door, and a team meets them at the door and gets them to a critical care team. Is there any conversation in the protocols that you guys are talking about that would discuss working with Uber and Lyft and other rideshare companies?
Not that great idea, but I'm not aware that this conversation is happening not only with us, but anywhere in the country. But it's a good idea.
I mean, it might be a good topic for the forum that is going to be happening in May or June, if this is a way. I mean, if an Uber or Lyft costs $8 to $10 and an ambulance ride is going to cost you $500 to $1,000, I don't even know how much an ambulance costs, but it's probably pretty expensive, and you're somebody who doesn't have great insurance, it might be an option for you, especially Ubers come pretty fast. You know, there's usually one within 2 or 3 minutes of your house. So maybe that's a great topic. Speaking to the technology piece that Councillor Zondervan brought up earlier, there's certainly technology that exists, and partnering with that technology is probably a good idea going forward. I'm just going to ask if my colleagues have any additional questions or follow-up questions from anything that you've heard earlier. Councillor Siddiqui.
Thank you, Councillor Mallon. When Mr. Posner was speaking about honoring Laura's life and the things that potentially we can think of, I thought about the broader issue of asthma, and I didn't know really how prevalent cases of asthma are, how serious they can be, and so I just think about the educational piece too. There's great organizations and foundations, and I think that could be a part of this, thinking about asthma prevention, thinking about making sure people know more about the topic. So that's just an idea, but I think that'd be important in honoring Laura's life.
Thank you, Councillor Siddiqui. I was also thinking about ways to honor Laura's life, both within the CHA and externally here in the city. I know there's these beautiful pictures of her enjoying the Charles River and her Harvard t-shirt where she was working. And as Councillor Simmons mentioned earlier, she is in the fabric of our community here. And if there's a way that we, as council members, can actually kind of come together around figuring out if there's a way to honor her memory, either at the Cambridge Women's Center that you said that she was doing resume workshops, or I know that she was doing some fitness empowerment around domestic violence victims. Or
well, that's part of a foundation I'm
Right.
starting in Laura's honor. Yes, yes.
So I know she had a number of things that she was interested in doing and volunteering, and I'm gonna talk with my colleagues and see if there's a way that we can come up with some ideas and maybe obviously partner with you and see if that's something that we can do as well. I am looking forward to seeing what the CHA is going to come up with. You know, I know that there's no opportunity for a monetary remuneration for the foundation that was founded in her name because of the way that the lawsuits and the cap are here in Massachusetts. I'm interested in that legislation and trying to figure out if that's something that can go forward in terms of removing the cap in certain circumstances. That's heartbreaking that there's not going to be some sort of financial remuneration for your pain and your loss. But, you know, if there's a way to talk about some kind of legacy that could exist here financially, if possible, I do look forward to hearing that from the board and from you, Mr. Wardell, going forward. Does anyone have any more questions? Mr. DeMarco, do you have any closing remarks?
I just want to once again thank everyone in this room. Number one, for remembering Laura, and number two, for taking her death seriously, and number three, I believe, for doing what you can to make sure that that this doesn't happen again, and there aren't any more Lauras. And I look forward to continuing to hear about more of your findings, more of your recommendations, more ways that CHA will be improving and sharing all this information, and ways in which the council will go forward with honoring Laura, and also just in making healthcare better for all the citizens, for everyone who goes to hospitals in Cambridge and elsewhere. Thank you all.
And thank you to the CHA and to the board, not only for being here today, but also for your work over the last several months in making sure that the communication is open and honest, and we get an outcome that is deserved for Laura. So I'm going to call this meeting adjourned. Thank you again, everyone, for being here.
Thank you.
Sure, it was nice. It was nice being in person. It really was. So. Thank you. It was so nice meeting you.
My computer died.
Oh no.
That's why I went up there.
No worries. I took like.
No, I had a little.
I can either go make a copy of these, email me, or just
My own.
yeah, just your opening statement. Yeah.
Came out something like this.
Okay. Do you want me to go make a